Good morning, everyone. Today I want to discuss about target temperature management. This target temperature management usually we will implement whenever the patient report from the successful cardiac pulmonary cessation. That is written as spontaneous circulation. If the patient is unresponsive to ROSC or any neurological signs will be present in ROSC, so can give a trial of target temperature management to recover the patient or to increase the success of patient after spontaneous circulation. So what is the meaning of target temperature management? Target temperature management it aims to reduce the mortality and improve the neurological outcomes in unresponsive patients who achieve ROSC after a cardiac arrest. So when we use in unresponsive patients who achieves no spontaneous circulation after cardiac arrest. In that situations only, can use the targeted temperature management. What are the objectives? How to identify the indication of target temperature management in patients with cardiac arrest. How to describe the phase of therapeutic hypothermia and outline the various complications that may occur in patients undergoing therapeutic hypothermia. And you can use the interpersonal stream strategies for improving the care coordination and communication to advance the target temperature management and improve the outcome after resuscitation from a cardiac arrest. These are all objectives of this topic. So let's come to the history. This target temperature management is not a new process. It started in 450 BC. The idea that cooling a person can slow a biological process and subsequent death was first described by Hippocrates in 450 BC, who advised packing a wounded soldiers in a snow. So in early 1800s, during French invasion of Russia, a battlefield surgeon noticed that the wounded soldier placed closer to the campfires died sooner, as increased temperature there. Then those placed cold in the polar blanks. Polar blank students, they will survive more than the campfire, closer to the campfires. And the clinical interest application of thermal hypothermia began in 1930s. The case reports on drowning victims who was rescued successfully despite the prolonged asphyxia. In 1943, Temple Fay published one of the first scientific papers related to the therapeutic hypothermia. Fay observed improved outcome of traumatic brain injury when temperature was lowered 38.3 to 32.2 to 32.7 degrees centigrade. So 1915 and 16, the clinical trials using very deep hypothermia or state have started but abandoned soon after due to the adverse effects occurred due to the hypothermia. In 1990s, again, the mild hypothermia was implemented in 3 cardiac arrest cases after successful registration. And all 3 made complete recovery without any residual neurological damage. Then again, everybody think of the mild hypothermia. So the therapeutic hypothermia began getting a serious attention after 2 prospective randomized controlled trials published in the New England Journal of Medicine in 2002 and found significant improvements in short and long-term survival as well as the neurological outcome. Today, now the term of target temperature management is used instead of therapeutic hypothermia because therapeutic hypothermia we can maintain some range, but target temperature management will target whatever the temperature we have to achieve. So TTM can be used to prevent the fever, maintain the normothermia, and to induce hypothermia. For 3 conditions, we can use the TTM. So coming to the thermoregulation is ability to maintain the steady state core body temperature by balancing the heat production and heat loss. By balancing there is a heat production and heat loss. It's a balance. So normal body temperature, everybody knows that that's 6.1, that's 1.8 degrees. This thermoregulator center is located in the hypothalamus and constantly receives inputs from the thermoregulator located in the hypothalamus on the skin and sweat glands, which monitor the internal external temperature. Decreasing the temperature, it activates the thermogenesis and heat conserving responses. The output of the hypothalamus is the sweat glands and skin arterioles, and adrenal medulla via the sympathetic nervous system, and skeletal medulla via the motor neuron. Shivering thermogenesis is the production of heat production during the hypothermia. So, afferent nerve stimulation results from rhythmic contraction of the skeletal muscle. Since there is no work being performed, most of this energy giving as a heat. The sympathetic stimulation also of superstructures arterioles of smooth muscle causes peripheral vasoconstriction, limiting the conservative heat loss and redirecting the warm blood to the core. One, by increasing the shivering, they will increase the temperature, and second, by increasing the sympathetic stimulation, they will redirect the blood from the cold form. So, what is the physiology behind the target temperature management? This target temperature management, it improves the neurological outcome and decrease the mortality through multiple mechanisms that alter the cascade of deleterious metabolic cellular and molecular changes that will occur following global ischemia. The important three main temperature dependent pathological processes that hypothermia acts on are one is ischemic brain injury, hyperfusion injury, and secondary brain damage. These are all the three we can see in the ROSC patients. So it will act on three mechanisms. One mechanism is decreasing the metabolic rate, reducing the neurotransmitter, and suppress the inflammatory cascade. So the first comes the decreasing metabolic rate. Hypothermia decreases the metabolic rate 5% to 7% per degree centigrade, decrease the core body temperature. So it's a protective phenomenon since when the metabolic rate decreases, oxygen consumption will occur. At the same time, it prevents the accumulation of other anaerobic metabolic waste products like lactate, other things, and reducing neurotransmitters. So accumulation of aspartate, glutamate, and other excitatory neurotransmitters also plays a significant role in a neuronal death following the cerebral ischemia. The severity of the excitotoxicity and neuronal damage is proportional to the quantity of these neurotransmitters. If the neurotransmitters are small, the aspartate, glutamate, and other neurotransmitters are more, they will increase the excitotoxicity of the neurons. So mild to moderate hypothermia is associated with the most profound reduction of glutamate levels compared to the severe hypothermia. So the hypothermia, it will decrease mild to moderate hypothermia will decrease the production of these neurotransmitters. And also the hypothermia decreases the free radical production and suppresses the various inflammatory processes that occur following the global ischemia and reperfusion. So suppressing the inflammatory cascade. The reperfusion occurs what after in ROSC, reperfusion causes a massive increase in the production of free radicals such as hydrogen peroxide, superoxide, nitrous oxide, hydrogen radicals. The high levels overwhelm the defensive antioxidant mechanism throughout the body and causes the peroxidation of lipids, proteins, and nucleic acids, which contribute to the neurological damage. These neuroprotective effects of hypothermia are associated with a significant reduction of nitric oxide and superoxide formation when the temperature reduces 31 to 33. The hypothermia suppresses inflammatory cascade and prevents the exacerbation of cerebral injury by decreasing the inflammatory mediators. By it inhibits the neuronal damage and it helps recover. So, what are the indications? These are several recommendations. In 2015, recommendation of Pojkari from the AHA includes TTM to treat the patient who are comatose after use of hospital cardiac arrest with initial rhythm of pulseless ventricular tachycardia and ventricular fibrillation. There is a class 1 recommendation by the American Heart Associations. And TTM to treat the patients who are comatose after in-hospital cardiac arrest and patients with a non-shock rhythm. So, when the patients are pulseless ventricular tachycardia, ventricular fibrillation, and non-shock rhythms also, the American Heart Association they will recommend the class 1 recommendation using TTM. In 2015, International consensus on CPR and emergency cardiovascular care science with the treatment recommendations from the ILCAR. ILCAR also recommends therapeutic hypothermia patients who are comatose after out of hospital cardiac arrest, initial shockable and non-shockable. And ILCAR also recommends therapeutic hypothermia for patients who are comatose after in hospital with an initial rhythm also. So both ILCAR and HA also they will recommend the hypothermia. What are the contraindications? Absolute contraindication of therapeutic hypothermia include hemorrhagic stroke, GCS more than 8, uncontrollable bleeding, and uncontrolled hemodynamic unstable rhythms, and cardiac arrest due to the trauma. These are all the absolute contraindications of therapeutic hypothermia, RTTM, and relative contraindications of thrombocytopenia, that is a platelet count less than 50,000, coagulopathy, and prolonged cardiac arrest. Cardiac arrest recovery takes more than 60 minutes, and refractory hypotension despite the fluid and vasopressor support. So refractory hypotension. So instead of giving the fluids and vasopressors also, the blood pressure not improved. That is called refractory hypotension. In all these conditions, TTM will be contraindicated. So here we have so many studies that will support the this therapeutic hypothermia. It starts from the 2002 to 2002. These are from the good neurological out of 49% of targeted temperature of 33 versus normothermia. If the studies goes on up to 2020, one more study is there. They did the favorable neurological outcome was 10.2% in a target temperature targeted hypothermia and 5.7% in a normothermia. So different studies also supports the to implement the targeted temperature management. So what is the procedure of target temperature management? So before starting the TTM, the patient should be hemodynamically stable and have a secure airway with optimal oxygenation. And also, the baseline clinical state should be assessed and hemodynamic monitoring should be replaced continuously. Ensure that following are obtained prior to initiation of target temperature management. Okay, so what are the different things that will be available for the TTM is baseline labs including ABG, cardiac enzymes, health CBC, BNP, INR, PT, APTT, and CPK, troponin, lactate should be available at any time. And continuous ECG monitor, and the endotracheal intubation, the mechanical ventilation, and pulse oximeter, and IBP, arterial catheter for invasive BP, central venous catheters, two large gauge IV access, and continuous temperature measurement, and Foley's catheter, and cooling equipment, and rewarming system. These are all the essential things while you are doing the TTM. So this target temperature, what are the different techniques and what are the different phases of TTM? In TTM, we can find three phases. One is the induction phase, maintenance phase, rewarming phase. So the main goal of the TTM is to achieve a core temperature between 13 to 34 degrees Celsius as soon as possible to maintain this temperature for at least 24 hours, then rewarm at a rate of 0.2 to 0.5 degrees per hour. So induction phase, induction of hypothermia, as soon as the patient is a process in which a target core temperature of 32 to 34 degrees is reached as quickly as possible. Hypothermia induction may be started in the ambulance or once the patient arrives at the hospital. Although it was thought that earlier cooling by the paramedics en route to the hospital would result in improved outcome due to the more rapid attainment to the target temperature. But there is no difference between the successful rate of the patients we start early target temperature or in the ambulance or in the hospital. So the pre-hospital cooling was performed. The paramedics with a rapid infusion of 2 liters of ice cold and lactate solution, which was found to decrease the core body temperature average of 0.8 degrees centigrade. So what are the three main categories of cooling methods? How will induce the target temperature management? What are the different methods? One is a conventional cooling technique, second is surface cooling technique, third is intravascular cooling technique. By these three techniques, you can induce the TTM. So conventional cooling technique, these consists of using a cold saline and ice packs, which are the simplest and most effective methods. The advantage of this conversion technique is that availability is widespread, it is easy to use, and it can be initiated by the paramedics in the field, and it is considered to be a safe method for hypothermia induction. And it can also be used to adjunct to more advanced cooling methods for the augment the cooling rate. So if you are using other methods also, you can use it as an adjunct method to get it more fast. So the disadvantage of conversion methods is that they are very labor intensive and often result temperature lower than the target temperature and are not effective in maintaining the target temperature. You cannot maintain the target temperature by using the conversion techniques. So surface cooling method. The surface cooling system using blankets, pads wrapped around the patient that circulate the cold air and fluid. These devices are less labor intensive and easier to use, with the most being equipped with the auto feedback mechanism that alter the water or air temperature to maintain the set target temperature. But disadvantages are skin burns or irritation, as well as risk of overshooting of the target temperature in the induction phase. Poor cooling systems. These currently consist of male intravascular catheters placed in a central vein that circulate the cold saline. These devices have a high cooling rate, the rates between the 2 to 4.5 degrees centigrade per hour. That will depend upon the size of the catheter and setting. They are considered the most reliable in all three phases of hypothermia induction. But the disadvantage are it is an invasive procedure and there is a possibility of catheter-related thrombosis. Other core cooling systems such as the peritoneal levels, extracorporeal circulation device, they are not widespread used yet. So intravascular cooling system, they are most reliable methods during the maintenance phase also, with fewer temperature fluctuation than the other cooling methods. So intravascular cooling method system is a ideal for induction at the same time maintenance phase also. So these are all the different systems you can see here. Ice packs applied in the torso back of the limbs, and infusion of cold saline, and this is a surface system cooling, and here cooling with the use of catheters, and intranasal cooling also here, and heat exchanger module directly incorporated the extracorporeal life circuits. This is a heat exchanger. Heat exchanger. This is a heat exchanger in the extracorporeal life support circuit. These are all the different techniques to induce the targeted temperature management. So how to measure the temperature after inducing the target temperature? So the temperature measurement is a vital achieving the accurate temperature measurement, preventing overcooling, assessing the variation in temperature during maintenance phase, and ensuring a steady state and control increase in temperature during the rewarming phase. So it's very important to prevent the overcooling and assess the variations, and at the same time rewarming phase also we can use this. The current gold standard of measurement is the temperature of blood by using the pulmonary catheter is a gold standard. The most commonly used other things are bladder, rectum, esophagus, tympanic membrane, but they exhibit a time lag between the registered temperature and measured core temperature. That's why they are not that much accurate. If a time lag is more, the efficiency will be decreases. This may lead to the overshooting of the temperature during induction. So the bladder temperature has a time lag of 20 minutes. Okay. And the esophageal temperature is the most accurate and most rapid and accurate the gold standard at an average of time lag 10 minutes. There is a lag time of 5 minutes. But the ideal depth of province is 32 to 38 centimeters from the mouth to esophagus. And this minimizes the chance of downward dislocation into the stomach. So a disadvantage is a possible interfering with a specific therapeutic and diagnostic process. That is a transitional echocardiography. When you are doing the transesophageal echocardiography and when you are putting a feeding tube, this esophageal temperature measurement that will affects. The rectal temperature average of 15 minutes of lag time. So we cannot rely on the rectal temperature because very long lag time. So rectal probe insertion is quick and easy process. However, there is a high rate of dislocation. So peripheral sites are completely inaccurate, which should never be used to guide the hypothermia. So rebound. In this phase, the core body temperature is gradually raised from 0.2 to 0.5 degrees centigrade per hour until it reaches the greater than 36 degrees Celsius. A slow rate of rewarming is associated with fewer complications, and rapid rewarming may negate and benefit the effect of therapeutic hypothermia. Upon reaching a temperature of 36 degrees centigrade, cooling devices and medication used to control the shivering can be discontinued. The rewarming phase starts from 12 to 24 hours after initiating the TTM induction, and it can take up to the 8 hours. So we have to do the rewarming very slowly. So what are the different complications of TTM and rewarming? So it will affect the cardiovascular, renal, electrolytes, immune, metabolic, and shivering and rewarming. So cardiovascular, including sympathetic stimulation, peripheral constriction, increase the catecholamic, increase the myocardial oxygen demand, and it decrease the risk of myocardial infarction also. And this therapeutic hypothermia are TTM, 25% increase the cardiac output, and increase blood pressure, and increase peripheral vascularization and sinus bradycardia. Maybe the complication of TTM, and serious arrhythmias may also occur while using the TTM. Renal, the cold-induced diuresis is important complication. This diuresis is caused by the combination of increased venous rate to secondary to vasoconstriction, increased ANP, decreased ADH, and tubular dysfunction. If left untreated, this diuresis, it causes hypokalemia, electrolyte imbalance, and hemoconcentration. Other electrolyte imbalance, electrolyte abnormalities, they may also cause therapeutic hypothermia. So by diuresis along with the tubular dysfunction, the intracellular ion shifts result in decreased concentration of several electrolytes, including the magnesium, potassium, and phosphate. So regular measurement and correction may be needed while using a TTM. Hypomagnesium, it causes the coronary and cerebral vasoconstriction, and it can exacerbate the reperfusion injury. Hypokalemia, hypophosphatemia can cause life-threatening tachyarrhythmias and respiratory muscle weakness that can increase the risk of respiratory infections and weaning from the mechanical ventilation. This electrolyte imbalance, they will affect the weaning also. The rewarming phase also has the electrolyte disturbances, and hyperkalemia often occurs in this rewarming phase due to the release of intracellular potassium may result in cardiac arrhythmias. So rewarming of the patient is a slow and controlled rate can prevent this complication by giving the kidneys more time to excrete the excess amount of potassium. And immune system also affected. The hypothermia, it causes inhibit the various inflammatory responses. It impair the secretion of pro-inflammatory cytokines, suppresses the leukocyte migration, phagocytosis. The hyperglycemia, peripheral vasoconstriction that often occurs with hypothermia, it contributes to the increased risk of infections. So the risk of infectious complication increase with the prolonged hypothermia. That's why high vigilance is needed, should be maintained, and certain measures should be taken to all hypothermia patients for the prevention and early detection of infections. These include regular microbiological surveillance and timely catheter placements, and examining the wounds and catheter insertion sites and avoiding the hyperglycemia. So timely, we need some vigilance regarding these infections. So metabolic complications, this hypothermia causes linear decrease in metabolic rate of 5 to 7 per degree core body temperature. This hypothermia shifts the oxygen hemoglobin dissociation curve to and reduces the shift to the left and reduce the tissue oxygen availability. And if the tissue oxygen availability is reduced, the anaerobic metabolism causes the development of metabolic acidosis. And the oxygen consumption, CO2 production also equally decreases. If the ventilation settings are not properly adjusted, the decreased carbon dioxide production may promote the respiratory alkalosis and hypercapnia. This results in cerebral vasoconstriction, increased cerebral vascularization, decreased cerebral blood flow. And the pharmacokinetic and pharmacodynamic alterations in a drug metabolism also occur by the patients of therapeutic hypothermia. The patients have received multiple drugs during the treatment course, including the paralytics, anticonvulsants, sedative, and cardiovascular drugs. So unanticipated drug toxicity may occur due to changes in the metabolism, especially since many of these drugs have a narrow therapeutic window. So the mechanism involved in these changes are drug specific and can occur one or more different phases of drug metabolism response and evaluation. So clinical studies evaluating the effect of hypothermia on the metabolism specifically found that there was an increase in the serum concentration and decrease the clearance rate and increase the duration of action. So by decreasing the metabolism of drug, they will cause increase the serum concentration, decrease the clearance, increase the duration of action. So we have to see that the frequency between the drug dosage we have to monitor. So metabolism gradually to the baseline when it occurs the reforming phase. So this TTH may be associated with a decrease in insulin sensitivity and decrease in insulin sensitivity by the pancreatic islets. Whenever the decrease in insulin sensitivity, decrease in insulin occurs, it leads to hyperglycemia. This hyperglycemia is also the poor neurological outcome and it increases the mortality also. However, it is unclear whether hyperglycemia is due to hypothermia or due to the initial stress of the cardiac arrest or resultant organic hypo. Whatever may be the reason, hyperglycemia will occur. This hyperglycemia will cause a poor neurological outcome. So shivering is one of the other more complications. It's a protective phenomena whenever the temperature concept below the 36.5 degrees Celsius. It produces the heat through the rhythmic contractions and relaxation of skeletal muscle, which increase the oxygen consumption and energy expenditure and induction time. These changes counteract maybe the beneficial effect of therapeutic rhythm. Therefore, shivering must be suppressed to decrease the oxygen consumption because the metabolic rate should be decreased in therapeutic hypothermia. This increases, it should be suppressed. This is achievable by the various pharmacological and non-pharmacological interventions and rewarming phase complications. So rewarming also has several complications. The most important are vector disturbance in the hemodynamic instability. So intracellular shift of electrons that occur during cooling is reversed in this phase. The resultant increase in extracellular ions, especially potassium, and can lead to the hyperkalemia and can lead to the cardiac arrhythmias. To prevent hyperkalemia, rewarming should occur slow and controlled rate. This allows the kidneys to exceed the excess amount of serum potassium. So renal replacement therapy should be initiated and bedside, besides the potassium containing fluid should be discontinued before the removal. And rewarming causes peripheral vasodilatation and redistribution of blood, resulting in hypotension, consequently reduce the tissue oxygen delivery. This can be prevented by the volume overload, the normal saline 4 to 8 hours before the rewarming. So we have to apply we have to stabilize the volume status just before the 4 to 8 hours before the rewarming. It is essential to closely monitor hemodynamics during this phase with a routine assessment of blood pressure, urine output, and serum lactate. So this TTH it affects all the systems. So neurological, cardiac, muscular, hematological, pulmonary, renal, and monitor. So it's a very complicated procedure, but it involves every system. It will use at the same time. It will use the benefits also. So TTM is a balancing act. We have to balance between the advantage and disadvantage. Then only we have to apply the targeted temperature management. Thank you.